Hello, this is the Open Anesthesia Sustainability Series. The topic for this session is the use of low gas flows for sevoflurane. Today, we will define low-flow anesthesia. We will touch on the environmental ramifications of using excess gas flows with sevoflurane and address the FDA warning related to Compound A. We will explain why these concerns are no longer considered valid. Additionally, we will discuss how our practice should change accordingly. This is the key question. Is it safe to practice the low-flow technique with sevoflurane? What is low-flow anesthesia? Low-flow anesthesia, LFA, is a technique in which the fresh gas flow is precisely adjusted to meet the patient's oxygen and anesthetic requirements, typically maintained at a rate of less than 1.0 liter per minute. For a comprehensive exploration of this topic, I recommend viewing our episode on low-flow anesthesia within the Open Anesthesia Sustainability Steps series. We need to change our practice of delivering sevoflurane at 2 liters per minute for several reasons. Reducing the flow rate of anesthesia gases minimizes waste by reducing the amount of excess gases expelled into the environment. Previous concerns about Compound A at low flows are now considered invalid. Additionally, using 2 liters per minute is wasteful. Instead, we should use flow rates below 1 liter per minute to maximize rebreathing and minimize waste, enhancing both sustainability and efficiency in our anesthesia practices. What is the environmental impact of sevoflurane? Sevoflurane, like other volatile agents, is a potent greenhouse gas, contributing to climate change. This impact can be quantified using the global warming potential, GWP, which measures the relative potency of a gas compared to carbon dioxide over a specific timeframe. GWP 20 is the effective heat-trapping effect of a compound measured over 20 years compared to carbon dioxide. Sevoflurane's ability to trap heat is 144 times that of carbon dioxide, indicating its substantial contribution to global warming. Moreover, there is an economic cost associated with excessive fresh gas flows, particularly at a flow rate of 2 liters per minute, which results in unnecessary expenses. Why are anesthesiologists resistant to low-flow delivery technique with sevoflurane? Anesthesiologists' resistance to low-flow sevoflurane can be attributed to several factors. Firstly, the influence of FDA-approved labeling plays a significant role, as practitioners often adhere closely to recommended usage guidelines provided by regulatory bodies. Secondly, there are concerns about Compound A, toxic byproduct formed when sevoflurane is degraded by CO2 absorbents. Lastly, professional habits and beliefs entrenched within the anesthesia community may contribute to resistance, as practitioners may be hesitant to deviate from established practices without compelling evidence or consensus within the field. In 1995, the U.S. Food and Drug Administration, FDA, recommended using sevoflurane with fresh gas flow rates of at least 1 liter per minute for exposures up to 1 hour and at least 2 liters per minute for longer exposures to minimize the risk of renal toxicity from Compound A. While this warning exists in the United States, other countries do not necessarily adhere to the same cautionary labeling, with low-flow techniques involving sevoflurane being a widely adopted practice internationally. What do we know about Compound A? Compound A is a byproduct formed when sevoflurane, an inhalational anesthetic, reacts with strong bases in CO2 absorbents used in anesthesia machines. Chemically known as trifluoromethylvinyl ether, Compound A is produced when sevoflurane degrades in the presence of strong bases like sodium hydroxide or potassium hydroxide. Animal studies, particularly in rats, indicated that Compound A could cause renal toxicity. Current clinical evidence does not support significant renal toxicity in humans. Manufacturers provide details on the composition of CO2 absorbents, including the strong bases sodium hydroxide and potassium hydroxide. Do you know what kind of absorbent you use at your institution? Do you know its composition? Modern formulations of CO2 absorbents have evolved to enhance safety and reduce the production of harmful byproducts such as Compound A and carbon monoxide. Many of these formulations have significantly reduced sodium hydroxide, NaOH, and entirely eliminated potassium hydroxide, KOH. The general trend among manufacturers is to develop CO2 absorbents that minimize or eliminate strong bases to mitigate the production of compound A and carbon monoxide. Here are some examples on the market as of 2024. It is advised to review the particular composition as current formulations are constantly changing. The FDA makes it clear that it doesn't regulate the practice of medicine. Similarly, the Federal Food, Drug, and Cosmetic Act of 1938 doesn't hold physicians liable for using drugs off-label. Physicians are required to maintain the same standard of care as their colleagues in similar situations, which defines their duty of care. Using medication off-label doesn't automatically lead to liability under negligence standards. While there are concerns about potential increased liability with off-label drug use, litigation stemming from such practices is rare and often defensible. A review of the closed claims database between 1987 and 2022 found 0 instances of successful litigation related to compound A or low-flow sevoflurane. A change in our practice is needed. To quote Dr. Forbes McGain, a leading researcher in healthcare sustainability, concern about theoretical compound A-induced nephrotoxicity in humans from low-flow sevoflurane has driven vast amounts of waste globally despite safety evidence 20 years ago and newer non-compound A-producing CO2 absorbents. A recent statement from the American Society of Anesthesiologists, ASA, supports low-flow anesthesia with sevoflurane. The ASA acknowledges outdated labeling recommendations and affirms that low fresh gas flows with sevoflurane are safe and offer economic and environmental benefits. The ASA fully endorses the use of low fresh gas flows alongside sevoflurane administration. For more details, visit the ASA website. Here are the key takeaway points. In modern anesthesia practice, low-flow sevoflurane has emerged as a preferred option, offering not only financial advantages but also environmental benefits. The traditional method of administering sevoflurane with fresh gas flows of 2 liters per minute is now considered outdated, due to research confirming the safety and effectiveness of low-flow sevoflurane. Most modern CO2 absorbents available in the U.S. contain minimal or no strong bases. The American Society of Anesthesiologists and the Anesthesia Patient Safety Foundation endorse the use of low-flow sevoflurane. Contributors to this video included Dr. Jacklyn Ma, Dr. Carole and Dr. Diane Gordon. Here are some references for low-flow sevoflurane information.